Good evening, sir.
Good evening.
So can we start, sir?
Why not? 6:30, it is sharp.
Yeah.
And we should go ahead.
So all the participants, you are most welcome to the 8th issue of the OcuHealth Escapes. Today on 30th of July 2021. This is our monthly edition of the occupational health issues, local, regional, and the global. And the session will be taken by none other than our Vice President, Dr. Rajiv Kumar Jain, who is member of the Management Committee, Scientific Committee on Epidemiology in Occupational Health, EPICO, International Commission on Occupational Health, and there are a lot of credentials to his credit. He is Senior Consultant Health in Indian Railways, New Delhi, and with 40 years of experience in health and hospital administration. And he is Fellow Award of Indian Public Health Association and Fellow of Association of Environmental and Occupational Delhi. He has published and presented more than 145 scientific papers in national and international conferences, journals, and books. And the fellowships, the scholarships by WHO, National Institute of Health, USA, Canadian Society for International Health, and International Clinical Epidemiological Network, and International Society for Practices, Priorities in Healthcare. So, Dr. Rajiv, sir, although we are discussing this COVID every week in Epic Updates and our INOC DigiConnect webinar series, but this initiative of AUSD, that is OcuHealth Escapes, that is an important issue for every one of us, and all industrial physicians, occupational health doctors across India and abroad also, they should be aware of what are the recent developments in the field of occupational health, because that will help us and that will guide us also to take some necessary steps in our places wherever we are working in our organizations, and it will give us a clear guideline. So in this COVID pandemic, with new norms of working, so we have started this particular program, and with this I request you to, sir, to start the presentation.
Thank you, Dr. Sandeep. And I welcome all the attendees here as well as on YouTube. Before I start, I would again like to remind all our viewers and listeners that DigiConnect webinar platform has 79 videos uploaded on YouTube, and the channel is subscribed by 108 YouTube subscribers, and it is increasing, and each video is around 2 hours of duration, and it is a collection of a very wide range of topics in occupational and environmental health. And whatever we discuss on every Saturday and last Friday of the month, we upload on that, so that whatever you miss over here, you can revise, recollect, and explore more on YouTube channel. And you can download the video also if you like to. So this particular episode of OcuHealthscapes again will focus on the developments in the field of environmental and occupational health during the past 1 month, whether they have happened in India or outside India, or whether they have happened in Asia or Europe or US. And there is a wide range of topics that we have selected for your kind listening and viewing, so that you get an overview of these issues. And if you want to explore more, you can access the original source and explore more. So we begin with the first topic. Next slide, please. The first topic that we are going to take up is this topic: how the pandemic and lockdown have hit labor market. It's so important for all occupational physicians to understand the linkage between the COVID-19 pandemic and the labor markets, and pandemic resulting in lockdown, how they have affected the labor markets. We shall discuss it for a little while before we proceed further. The 2019-20 periodic labor force survey, which was released last week by the National Statistical Office, has shown a fall in unemployment rate from 5.8% in 2018-19 to 4.8% in 2019-20. Now, since this PLFS follows the July-June timeline rather than the fiscal year, which is April to March period, the 2019-20 report includes a 68-day-long hard lockdown. Now, does it mean that there was no distress in labor markets during the lockdown? Well, the headline employment numbers in the latest report might be misleading, and a careful reading of the report and the unit level data does show signs of pandemic-driven distress in labor markets. Let's see what is the evidence. Next slide, please. This is the first evidence. Unemployment rate, labor force participation rate, and WPR, that is work participation rate. These are the three most important numbers in this PLFS report. They are the labor force participation rate, that is LFPR, work participation rate, WPR, and unemployment rate, that is UR. LFPR is the share of population in a given age group which is either working or looking for a job, while WPR is the share of population which is actually working, and UR is a percentage of unemployed persons in the labor force. There have been 3 PLFS reports so far, the latest one covering the period from July 2019 to June 2020. A comparison of the 3 reports show that LFPR was the highest in 2019-20 and unemployment rate the lowest, but these numbers hide more than they reveal. This is in the subsequent slide, you will see how and what is the evidence for this. If you see 2017-18, 18-19, 19-20, 19-20 is the darkest blue, the bottom, and 6.1 to 4.8 it has come. Labor force participation rate has increased from 36.9 to 40.1, and worker population ratio has also increased from 34.7 to 38.2. But this is not the truth. This is not the complete truth. This is the partial truth. Let's discover the more deeper truth. Next slide, please. COVID, as you know, had forced a distress-driven rise in rural jobs. If you recollect, Manrega numbers increased because urban jobs were driven to rural areas and government had to give an incentive for rural employment, and Manrega was activated. If you look at the graph, which is in red and blue at the top, sector-wise change in employment between April-June 2020 and April-June 2019. In mining and quarrying, there was 44% decrease. Construction, there was 26% decrease. Financial, real estate and professional services, 16% decrease. Manufacturing, 8.9% decrease. Trade, hotels, transport, storage and communication, 8.7% decrease. Public administration, defense and other services, 8.3% decrease. Electricity, gas, water supply and other utility service, there was increase of 16.7%. Agriculture, forestry and fishing, again an increase of 5.2%. So images of thousands of migrant workers walking back to villages after the lockdown are among the most graphic memories of economic distress during the pandemic. 2019-20 PLFS offers the first official proof of this distress. In keeping with the established wisdom on economic transformation, the share of agricultural employment in India has been falling gradually. But 2019-20 was an exception to this trend, when agricultural employment actually increased from 42.5% in the 2018-19 PLFS to 45.6% in the 2019-20 PLFS. A comparison of absolute numbers of jobs by sectors shows that agriculture more than compensated for the job losses in all other sectors of the economy in the April-June 2020 period, which is the lockdown period. The picture becomes even clearer once we look at the quarterly number of April-June 2020 and April-June 2019. On a year-to-year basis, urban India saw a reduction of 11.05 million jobs in the April-June 2020 period, and rural India saw the addition of 14.7 million jobs. Please remember, the addition of jobs in rural areas was more than reduction in urban jobs. However, the unemployment rate, which is the share of people looking for jobs who did not find one, it increased in both rural and urban areas. As is obvious, unemployment rate increased more sharply in urban areas, that is from 8.9% to 20.8%. Then in rural areas, like that is from 8.57 to 12.2%. The reason unemployment numbers did not increase on an annual basis, despite a sharp rise during the lockdown months, is simple. They decreased sharply in the July-September 19 and the October-December 19 quarters, and to a lesser degree, even in the January-March 2020 quarter. That there was distress in urban job markets was obvious from the quarterly PLFS report in April-June 2020, released in March this year, which covers only the urban areas. Where the annual report usually really offers an insight is a rise in what seems to be distress-driven rural employment. So people in different stages of employment, you see in rural at the bottom. Next slide, please. Now, what happened to wages during the lockdown? In the graph, you are seeing a change in real wages between April-June 2020 and April-June 2019. Regular wage and salaries is in blue, casual labor is in pink, and self-employed is in red. Now, what happened to wages? The short answer is they fell sharply. The PLFS gives wage data for three kinds of employment categories. That is regular wage, salaried, casual workers, and self-employed. The self-employed were the worst hit during the lockdown, while regular wage workers suffered a contraction in incomes only in rural areas. The plight of self-employed workers was the worst in urban areas, where real wages fell to 75% of what they were a year ago. While regular wage workers do show an increase in wages at the national level, they only account for about a quarter of the total workers in the data from the periodic labor force survey. But that is the reality of the lockdown. Next slide, please. Now, underemployment also increased during the pandemic and lockdown. What you're seeing in the graph is a percentage change in average number of hours worked. The self-employed is in red, regular wage and salary is in blue, and casual labor is in pink. And you are seeing how there has been sharp decrease, sharp underemployment. To be sure, both employment and wage statistics do not capture the actual stress in labor markets after the pandemic. This is borne out by another statistics in the PLFS, the average number of hours for which work was available to different kind of workers. An average worker worked for 46.5 hours in a week in the April-June 19 period. This came down to 37 hours in the April-June 2020 period. So urban areas reported a bigger reduction because both regular wage and self-employment recorded a big decrease in hours of work on account of the hard lockdown. The self-employed were the biggest losers in urban areas, while regular wage earning workers were the biggest losers in rural areas. An unprecedented increase in share of agricultural employment underlines the rise in distress-driven employment during the pandemic. This is said by Professor Himanshu, who is an associate professor of economics at the Jawaharlal Nehru University in New Delhi. It is a well-known fact that more people join the workforce during periods of economic distress to compensate for the loss of incomes, and the situation must have become worse given the fact that the government offered very little in terms of direct support during the pandemic. So this is a truth which is important for all occupational health physicians to understand, and because only through that understanding they will be able to really drive the occupational health as a profession to be able to reach the last person who is working in our country and in the world. Let's take up another issue. This is the pandemic has fed on existing inequality and it has generated more inequality. This is being shown by the World Economic Outlook database. The International Monetary Fund has kept its global growth forecast for 2021 unchanged at 6%. However, there is a catch. Advanced countries will now grow at 5.6% instead of 5.1% projected of April 2021. As is obvious, this means that the countries outside the advanced world will now grow at a lower than expected pace. This is yet another evidence of the pandemic's disproportionate burden on the poor. In fact, it can now be argued that the COVID-19 pandemic has fed off existing inequalities in the world to generate more inequality. The advanced countries have further closed their growth gap with the rest of the world. So this is another concern, the fact that that growth in developed countries will improve, while in developing countries, it will further decrease. Next slide, please. A bigger but also cheaper fiscal stimulus is what drove the growth recovery in advanced economies. What you are seeing is in the graph is the fiscal deficit in different country groups, where fiscal deficit as percent of GDP in 2021 figures are projections, where the world is in dark blue, advanced countries are in green, emerging market economies are light blue, and low income developing countries are at the bottom in red. So the stronger growth rebound in advanced countries is a direct function of fiscal support by the governments. Now, fiscal deficit numbers are a testimony to this. Fiscal deficit as a percentage of GDP was 2.5% in 2018 and 3% in 2019 in advanced economies. These numbers were 3.8% and 4.7% in emerging market economies, and 3.4% and 3.8% in low-income developing economies. The situation changed completely when the pandemic hit. In 2020, advanced economies ran the biggest fiscal deficit at 10.9% of GDP, with a more than threefold increase compared to the 2019 level. And emerging market economies and low-income developing economies increased their fiscal support by a much smaller margin. Their deficit rose to 9.7% for the former and 5.5% for the latter group in 2020. These are advanced countries are likely to enjoy a higher fiscal support in 2021 as well. One of the reasons that advanced countries could run higher fiscal deficits financed from the borrowing is that they have lower borrowing costs than their emerging market and low-income peers. For example, the interest rate on 10-year US government bonds is less than 2%. This number is more than 6% for India and more than 12% for Nigeria. When countries are borrowing to fund fiscal deficit, debt sustainability, which is also a function of borrowing cost, is always a big determinant of the fiscal stimulus a country can provide. And mind you, this will affect the growth of India, and this will affect the job scenario. This will affect the industrial development of India in the years to come. Next slide, please. Lag in vaccination in poor countries will continue to generate headwinds for growth. Vaccine courses administered as percentage of population is shown on the right side as a graph. Delivered is in blue and administered in percentage is in yellow. World, you are seeing at the top, then advanced economies, then emerging market economies, and bottom is low income and developing countries. You see the sharp decline from 38.6% to 1.4% from advanced economies to low income developing countries. The reason COVID-19 pandemic is different from any other economic crisis is that economic recovery is also contingent on there being no fresh outbreak of infections. India's growth forecast for 21-22 has been cut by IMF from 12.5% to 9.5% for the second wave of infection. There was a level playing field on this count as long as vaccines for COVID were not available. This is not the situation anymore. There is a huge difference between the pace of vaccination in rich and poor countries as a later struggle with sourcing and affordability issues. Countries that placed bulk orders even before the vaccine were proven successful, which is a function of resources, research ability, a well-developed pharma sector, and the presence of local vaccine manufacturers have led an advantage over others in sourcing vaccines. According to July World Economic Outlook update of the International Monetary Fund, 34.7% of the population of advanced countries have been administered vaccines so far, to compare to just 9.8% and 1.8% in emerging markets and low-income countries. A blog by the IMF chief economist Geeta Gopinath has identified vaccination progress as the critical factor behind growth upgrades and downgrades compared to the April projections. Faster than expected vaccination rates and return to normalcy have led to upgrades, while lack of access to vaccine and renewed waves of COVID-19 cases in some countries, notably India, have led to downgrades. At 4 p.m. on Thursday, that is yesterday, 10.4% of India's adult population had received both doses of COVID-19 vaccine, while another 26.9% were partially vaccinated. Next slide, please. Employment loss has been bigger for the poor workers and poor countries. So this is another global evidence. Earlier I had shown India's evidence. Now this is shown by IMF as well, globally. So poorer the country, employment loss will be bigger. This is an inequality in growth recovery is not the only fallout of the pandemic. In India, there has been ample evidence of what has been termed as a profit-led as opposed to a wage-led recovery. As the fear of infection and new waves persist, blue-collar workers, especially in contact-intensive industries, continue to suffer more than their white-collar counterparts. The latter have the luxury of working remotely. The IMF update has also underlined this fact. Moreover, the employment recovery is highly uneven, with youth and low-skilled workers across economies and women in emerging market and developing economies remaining harder hit. Combination of factors may explain why employment rate remain subdued. They include a continuation of the health crisis, which still prevents a full reopening, workers' concerns about health risks in the workplace, and firms' reluctance to hire new workers, given lingering uncertainties about the recovery. So this is the larger picture I wanted to share with you, which has been shown by Government of India's Labour Survey and the International Monetary Fund through their economic outlook, which has been released during the past 1 week. Next slide, please. Let's take another issue now. This is another evidence which this article has been published in Nature, where it has been shown that the pattern of flow of interstate migration based on 2011 India census has been shown graphically. The migration in terms of millions, the darker red is higher migration, the light yellow is the lower migration. But look at the geographical migration in India. Majority of migration occurs from northern India, mainly Uttar Pradesh and Bihar, and which is the maximum center which attracts the maximum migrants. It is Mumbai, the red, and also Delhi, and also South India, Bangalore. And where do they go? They go to these three places from Uttar Pradesh and Bihar, but they also go to West Bengal, Kolkata. They also go to central India, Bhopal. And they also go to northwestern India, that is Punjab. You see these waves and lines, they show how migration pace occurs in India. I'll show you the original article in Nature Climate Change. Next slide, please. This is the climate hazards are threatening vulnerable migrants in Indian mega cities. This is the article which has been published in Nature this month. And this has been written by people who are based in India, but they are working in US. And it starts with the first paragraph I'll share with you. In recent decades, India has witnessed a rapid pace of migration from areas with intensive agriculture to populated megacities, which are faced with increasing threat from climate hazards. Greater attention is needed for vulnerable new migrants who lack necessary resources when designing adaptation and mitigation policies. That is the thrust of this article. Next slide, please. I'll share with you the insights for the occupational and environmental health physician. External shocks usually have detrimental effects on the coping capacity of marginal migrants. This was, for example, starkly evident during India's COVID-19 lockdown in 2020. The reverse migration of around 40 million marginal migrants from urban areas back to their respective places of origin in a span of few days highlights the vulnerability of migrants in the face of external adversity. Such increased vulnerability of socio-economically disadvantaged migrants from rural areas is a common concern for not only India, but also other developing countries experiencing both climate threat and rapid urbanization. Therefore, concerted efforts should be devoted towards capacity building and adaptation actions to not only accommodate these migrants in the megacities, but also ensure that they can withstand the vagaries of climate-related hazards. While devising policies for climate mitigation and adaptation, special focus needed for alternating the vulnerability of the marginal migrants in megacities and other destinations. That is the observation of this article. A very evidence-based article and worth reading. This has been published in Nature Climate Change. Nature Climate Change is a journal which is in the Nature group of science magazines. Next slide, please. This is another decision support system which has been devised by Indian Institute of Tropical Medicine in Pune, where scientists are working on advancing the accuracy of the model. And the aim is to start releasing the data procured by this new system by October 2021, when stubble burning starts in Haryana and Punjab. Now, what is this IITM Pune's decision support system? It is the first of its kind, a real-time model to assess the contribution of pollution sources in Delhi. The system was developed on the request of the erstwhile Commission for Air Quality Management, CAQM, in Delhi and adjoining areas. It will now be managed by the Central Pollution Control Board. In this model, tracers have been attached to 8 major polluting sources that have been identified in Delhi. The share of the sources at any given time will also be shown. The system will also be able to track the contribution of crop stubble burning from states such as Punjab and Haryana to Delhi's air. And it will be ready by October 2021. How will this system, this model help Delhi? Delhi will be able to track in real time which sources are contributing to pollution. The model will also be able to give the share of these sources at any given time. And third, apart from Delhi, the model will also be able to track pollution contributors from 19 districts in Delhi NCR, which are visible in the map, which is shown in yellow on the right side. These are NCR districts like Karnal, Muzaffarnagar, Panipat, Jeend, Rohtak, Sonipat, Ghaziabad, Gautam Budh Nagar, Bulandshahr, Faridabad, Gurugram, Rewari, Alwar, and Bharatpur and Bhiwani. These are the districts which will also show the sources like energy, industry, waste burning, traffic, dust, construction, and residential. So these are the sources which will be traced by this new system developed by Indian Institute of Tropical Medicine, Tropical Meteorology, Pune. Now let's take up another issue. This is another important data which has been released by Indian Council of Medical Research, which is the Indian ICMR Young Diabetes Registry. This is the largest national registry for youth onset diabetes in the world. And they're headquartered in ICMR, but it has centers across India, right in North India and South India, where the centers are developing evidence or data regarding individuals developing youth onset diabetes. Database of 10 variants of diabetes, including youth onset type 1, 65.6%, and type 2, 24.1% diabetes. Follow-up data available for the past 20 years, that is from 2001 to 2020. Next slide, please. This is the national study on diabetes and non-communicable disease in India from 27 states and 2 union territories, including the National Capital Territory of Delhi. And this again remains the largest epidemiological study on diabetes in India, with 113,043 adults surveyed. National representative sample is there, and data is available on diabetes, pre-diabetes, hypertension, obesity, dyslipidemia, and other risk factors. The burden of diabetes in India is 77 million. ICMR India B study shows that there is a high burden of diabetes, pre-diabetes, and other non-communicable diseases among urban and rural population. What are the figures? Diabetes prevalence ranges 4.3% to 13.6%. Pre-diabetes prevalence ranges 6% to 14.7%. And hypertension prevalence ranges 25% to 30.2%. Look at the high numbers in India. This is the real hard evidence, and all occupational health physicians must be able to realize this is the biggest challenge that each occupational health physician will face in the workplace. Next slide, please. Highest prevalence of diabetes in 3 states, that is Kerala, 23.5%, Goa, 23.3%, and Pondicherry, 20.3%. Lowest prevalence of diabetes, the 3 states are Uttar Pradesh, 4.2%, Bihar, 4.3%, and Meghalaya, 4.5%. What about pre-diabetes? 14.3% in urban areas and 14.4% in rural areas, the same figure. But the highest prevalence of pre-diabetes is in Sikkim, 31.8%, Pondicherry, 24.1%, and West Bengal, 23.1%. While the lowest prevalence of pre-diabetes, the 3 states are Mizoram, 6%, Manipur, 7.5%, and Jharkhand, 8.1%. What about obesity? The prevalence of obesity in urban India, 37%, rural India, 22.8%. Look at the high numbers. What is the what are the states with highest prevalence of obesity in India? Pondicherry, 45.9%, Kerala 43.6%, and Delhi 41%, 41.8%. Which are the three states with lowest prevalence of obesity? Jharkhand 11.7%, Meghalaya 13.9%, and Bihar 14.5%. Next slide, please. Let's look at hypertension. In urban India, 35%, and in rural India, it is 30%. Highest prevalence of hypertension, the three states are Sikkim 44.4%, Punjab 44.3%, Kerala 44.2%. Lowest prevalence of hypertension, the three states are Meghalaya 23.4%, Madhya Pradesh 23.7%, Mizoram 25%. Look at the high rate of hypertension across, even the lowest is very high. Prevalence of hypercholesterolemia in India, urban is 25.2% and rural is 20.7%. Again, very high. Highest prevalence of hypercholesterolemia in three states are Kerala. Look at the number, 49.9%. Goa, 47.7%, and Himachal Pradesh, 37%. While the lowest prevalence of hypercholesterolemia is in Jharkhand, 4.9%, Assam, 6.9%, Arunachal, 9.5%, and Meghalaya, 9.5%. So this is a real data for real people in the states and in our country, in urban areas and rural areas. So we need to have effective interventions in the workplace to control and prevent hypercholesterolemia, obesity, hypertension, diabetes, and pre-diabetes. And this is the evidence which is available. Now we'll go to another issue of immense importance. This is an overview of disease burden preventable through sound management and reduction of chemicals in the environment. And this has been released by World Health Organization. On the left are the group of chemicals, and the disease outcomes considered are in the middle. Deaths and disease-associated life years are on the right side. Chemicals involved in unintentional acute poisoning is 61,000 deaths and 34,89,000 life years lost. Chemicals involved in unintentional occupational poisoning is 8,600% death and 4,70,000 disease-associated life years lost. Pesticides involved in self-inflicted injuries, deaths are 1,37,000 and disease-associated life years lost is 62,45,000. Chemicals involved in congenital anomalies, 26,643 deaths and 25.89 lakh disease-associated life years lost. Single chemicals with mostly longer-term effects. Lead, cardiovascular disease, 4.6%, chronic kidney disease, 3%, idiopathic intellectual disability, 30%. 90,000 deaths, which is 9 lakh deaths, which is CVD is 8 lakh deaths, and CKD 52,000 deaths. Chemicals in occupational exposure, longer term effects, cancers 2.9%, pneumoconiosis 79%. Occupational particulates like dust, fumes, gas, COPD, and pneumoconiosis 16% and 21%. 5,24,000 COPD deaths and 5,17,000 due to COPD and 6,500 due to pneumoconiosis. And life years lost is 1 crore 17 lakh COPD and 1 crore 15 lakh pneumoconiosis. So total, considering all the diseases, is 20 lakh 2,000 deaths, which is 3.6% of total deaths, and total disease-adjusted life years lost is 5 crore 34 lakh 81,000 days lost. Next slide, please. This is the total deaths attributable to chemicals by disease, includes risk assessed earlier. Largest is cardiovascular disease, second is COPD, third is cancers, fourth is self-harm, fifth is unintentional poisoning, and sixth is chronic kidney disease, and 7 is congenital anomalies. And pneumoconiosis also contributes. Next slide, please. These are the deaths attributable to chemicals by sex. Males is on the left side, females on the right side. So deaths per 1,000 population, 0.32 due to non-communicable disease and 0.03 due to injuries in males. In females, deaths per 1,000 is 0.15 for non-communicable disease and injuries are 0.02 per 1,000 population. Next slide. These are the latest figures. This is what you've seen age-wise, percentage of global deaths attributable to poisonings by age. So on the left side, the y-axis is percentage of deaths, and on the x-axis at the bottom, age in years from 0 years to 85 years. And look at it, the highest is at age 15. So age 15, children and young adults are particularly affected by unintentional poisonings. This is the peak period, children and young adults. Next slide, please. This is the countries with legally binding controls on lead paint based on information from governments as on December 2020. Only 41% of countries have confirmed that they have legally binding controls on the production, import, sale, and use of lead paints. And India is one of them. And no is in yellow, a yes is in blue. So large part of Africa, a part of Latin, South America is yellow. They have yet to implement the production, import, sale, and use of lead paints. Next slide. This is the poison centers as on January 2021. The red dots that you see, a poison center is a specialized unit that advises on and assists with the prevention, diagnosis, and management of poisoning. Only 47% of countries have a poison center, with particular gaps in the African and Eastern Mediterranean regions and in the small island states in the Western Pacific region, where you don't find any dots. In India, you can find dots. The central India is devoid of poison centers, while they are in North India, and number of centers is South India, as well as Western India and Eastern India, but not in Northeast India. You should see the red dots in India. And concentration of poison centers in Europe and Northern America, especially USA. Next slide, please. International Labour Organization released this exposure to hazardous chemicals at work and resulting health impacts, a global review this month at Berlin, where international meeting was held between ILO and WHO, and a consensus attempt was being made. So exposure to hazardous chemicals at work and resulting health impacts, a global review, is an important publication worth reading. It's a 95-page document. I will share with you the highlights of this document. Next slide, please. This is the global burden of global work-related diseases by regions and the total number of work-related fatalities, which was 2.4 million. At the bottom, you are seeing the AFRO, AMRO, EMRO, and Euro, CRO, and WPRO region of World Health Organization. Occupational injuries are in blue at the top. So highest you see is in the African region and the Southeast Asia region and the Western Pacific region. And the lowest are in European region. That is occupational injuries. These are work-related diseases. Genitourinary diseases is in black. Digestive diseases are in yellow. Respiratory disease, which is important for India, they are the highest. They're in light blue, and you see Southeast Asia region showing the highest proportion. Circulatory diseases are highest, which is red, in European region, but they are prevalent in all other regions as well. Neuropsychiatric conditions are in green. Highest you are seeing is in American region. Malignant neoplasm you are seeing highest in Western Pacific region and the American region. While communicable disease, highest you are seeing in the African region, also in Southeast Asia region, as well as Eastern Mediterranean region of the WHO. So what you're seeing blue is communicable disease, and this is a global work-related disease by regions. Next slide. This is a graph which shows the sectors with prevalent female workforce, representing 63% of global employment. And mind you, data from China and India was not made available. Personal care workers, women is 88%, in health associate professions 76%, cleaners and helpers 74%, general and keyboard clerks 71%, health professionals 69%, teaching profession 68%, customer service clerk 66%, other clerical support workers 61%, food preparation assistant 60%, personal service workers 56%, legal, social, cultural, and related associate professions 52%. And the lowest is numerical and material recording clerk 51%. And gradually you see from the top to bottom, the proportion of men increases. Next slide. This is the sectors with prevalence male workforce participation. That is blue. These are sectors which are dominantly done by men across the world. If you look at it, building and other related trade workers are 97% male, drivers and mobile plant operators 97%, metal machinery related trade workers 96%, armed forces occupation and other ranks 95%, non-commissioned armed forces 93%, electric and electronic trade workers 91%, commissioned armed forces officers 90%, science and engineering associate profession 84%, protective service worker 84%, and laborers in mining, construction, manufacturing and transport 83%. So very few women participate. Next slide. This is the asbestos, silica, heavy metal, that is lead, heavy metal, mercury, solvents and dyes, and how they cause impact on health. Asbestos causing cancer, mesothelioma, cancer of the lung, larynx, ovary, and asbestosis and pleural disease. And global burden of occupational exposure is more than 125 million. Work-related health impact is more than 233,000 deaths annually. So what is the action required? That is, phase out of asbestos has proven effective and has already been implemented in over 50 countries. Continued use and exports from low and middle income countries, it continues to pose a threat to workers, and effective and safe substitutes are needed. What about silica? Silica causes lung cancer and silicosis. And health and global burden of occupational exposure is more than 50 million. And limited data covering 35 countries. This is OSHA 2002 and IOM 2011. More than 65,000 deaths annually. Sandblasting bans, regulation and OELs have proven effective and have been successfully implemented, in particular in high-income countries. Continued efforts are needed in selected sectors like textiles and masonry, as well as low and middle-income countries. What about heavy metal like lead? It causes cancer of the stomach, neurotoxicity, and cardiovascular disease. What is the occupational burden? More than 1.8 million. This is by UE OSHA 2014 and CareX Canada 2020 estimate. Limited data is available to show what is the impact. And more than 900,000 due to environmental lead exposure has been there. What action is required? Phasing out of lead from gasoline, paint and batteries has proven effective in reducing human exposure in selected regions. Further, global efforts are needed, particularly in low and middle income countries, and updated and harmonized OELs are needed. For mercury, it causes neurotoxicity, nephrotoxicity, immune toxicity, and reproductive toxicity. Now, over 19 million is the global burden of occupational exposure, and limited data is available on work-related health impact. Though there is data, more than 2 million DALYs attributable to chronic metallic mercury vapor intoxication. Action required is stronger workplace prevention efforts are needed, as well as phase out across various economic sectors. The Minamata Convention has been implemented in over 120 countries. Nevertheless, targeted strategies are needed at both the national and workplace level to protect workers' health, particularly in low and middle income countries and in the informal economy. Now we come to solvents. Solvents, of course, they cause cancer, neurotoxic effects, including chronic solvent-induced encephalopathy and reproductive toxicity. Data regarding burden of disease due to occupational is limited, and similarly is the work-related health impact. What we need to do, the phasing out and ban of the most hazardous solvents has proven effective in selected countries and regions. However, national laws and workplace regulations are still needed in the majority of workplace settings. Increased efforts are needed in low and middle income countries and the informal economy. Last is the dyes. The cancer of the bladder is caused by this. Data is very limited regarding its health impacts and work-related disease, occupational exposure. What is required to do is the phasing out and ban of the most toxic azo dyes has been effective and successfully implemented, in particular in high-income countries. Evidence-based and harmonized OELs must be developed for all the dyes. Next slide, please. Now we come to manufactured nanomaterials. Limited data is available. It causes cancer of mesothelioma of the lung, and national regulations based on evidence from risk assessment should be developed for these nanomaterials. Different OELs have been implemented, but evidence of the effectiveness of these OELs is still limited, and harmonized OELs are missing. Now we come to perfluorinated chemicals, that is PFAS. They cause cancer, testicular cancer, liver cancer, and kidney cancer. It causes immune toxicity, liver toxicity, and reproductive toxicity. Limited data is available about its effect on the human being and how much occupational contribution it does. But it does cause substantial. PFOS and PFOA have been phased out in different countries. However, these substances can bioaccumulate and remain in tissue long after they are removed from use. There are currently thousands of PFAs still in use, and the effectiveness of OELs and other protective measures to prevent risk in workers are still unclear. Another important item is endocrine disrupting chemicals, that is EDCs. They cause reproductive toxicity, obesity, diabetes, neurotoxicity, cancers of the breast, and the cancer of the prostate. What we know is that more than 20 million IQ points are lost because of this. More than 8 lakh cases of male infertility in the US and Europe due to environmental exposure at normal levels. And this data came in 2016 by Gisande and Achina. The phasing out and ban of the most toxic EDCs has been successfully implemented, in particular in high-income countries. Increased efforts are needed to identify EDC exposure and to implement control strategies in LMIC. Gender consideration should be mainstreamed in OSH regulations. We come to important item, that is pesticides, because poisoning, cancer, neurotoxicity, endocrine disruption, reproductive toxicity. Limited data is available for, although presumably a significant number of global agricultural workers may be exposed, approximately 883 million agricultural workers. This is ILO 2019 and Carvalho 2017. More than 3 lakh deaths annually due to pesticide poisoning, with more than 10,000 fatalities due to unintentional acute poisoning, acute pesticide poisoning. What is required to be done is the phasing out and ban of the most toxic HHPs has been successfully implemented, in particular in high-income countries. Increased action is needed for low and middle-income countries, particularly for regulation and practical workplace prevention efforts. OELs for HHPs should be implemented and enforced globally. Now we come to the last but not the least, workplace air pollution. Cancer of the lungs, respiratory disease, and cardiovascular disease are caused by workplace air pollution. More than 1.2 billion people are affected, and more than 860,000 deaths annually. This is WHO estimate of 2018. Targeted pollution control strategies being successfully implemented, in particular in high-income countries. More efforts are needed to design and implement workplace prevention measures with a focus on LMICs. Next slide, please. Occupational exposure to asbestos causes an estimated 233,000 deaths each year worldwide. 125 million people are estimated to be exposed to asbestos at the workplace. Next slide. Major producers continue to produce and export asbestos to countries around the world, especially low and middle income countries. Main sectors of exposure are mining, construction, agriculture, plantation, other rural sectors, automotive industry, and protective textiles. Primary health impacts are cancer, mesothelioma, cancer of the lung, larynx, and ovary, and also asbestosis and pleural disease. Global burden of occupational exposure is 125 million, as estimated by WHO. Work-related health impact is more than 233,000 deaths. This is the global burden of disease estimate of 2019. Next slide. Go to previous slide, please. This is about asbestos. We come to silica. Next slide. This is in mining, construction, agriculture, plantation, and other rural sectors, and oil and gas, and manufacturing of non-metallic mineral products. For example, pottery, ceramics, bricks, stone cutting, shaping, and finishing. Niche industries using abrasive sound blasting, for example, textiles, garments, and restoration. Primary health impact is cancer of the lung and silicose. More than 50 million deaths, 50 million occupational exposure. This is the burden. Health impact is more than 65,000 deaths annually. Next. Globally, 14 to 19 million workers are employed as artisanal small-scale gold miners. 25 to 33% of these miners suffer from chronic metallic mercury vapor intoxication. Low and middle income countries carry the largest burden of exposure for all heavy metals. Next slide, please. This is what you see is main sector of exposure are mining, construction, agriculture, plantations, and other rural sectors, manufacturing, basic metal production, shipping, ports, fisheries, inland waterways, utilities like water, gas, electricity, textiles, clothing, leather, footwear, and mechanical and electrical engineering sector. Substances are lead, mercury, arsenic, cadmium, and hexavalent chromium. Primary health impact is various cancers like cancer of stomach, neurotoxicity, and cardiovascular disease for lead. For mercury, neurotoxicity, nephrotoxicity, immune toxicity, and reproductive toxicity. For arsenic, cancer of the lung, skin, urinary bladder, and skin toxicity, neurotoxicity, and nephrotoxicity. For cadmium, cancer of the lung, nephrotoxicity, and bone toxicity. For hexavalent chromium, cancer of the lung, nephrotoxicity, lung toxicity, skin toxicity, and liver toxicity. Global burden of occupational exposure for heavy metal is more than 25 million. For lead, it is more 1.8 million. The OSHA 2014 estimate. For mercury, more than 19 million, which is limited data for artisanal small-scale gold mining only. More than 3 million for arsenic, more than 5 lakh for cadmium, and for hexavalent chromium, it is more than 1 million. This is the global burden of occupational exposure. Workplace work-related health impact is there is very limited data for all except for mercury, where some evidence is available that 2 million deaths attributable to chronic metallic mercury vapor intoxication is the data available in 2017. Next slide, please. More than 60 chemical elements can be found in electronics. The majority of the workforce in the electronics industry are young women, and case studies have shown increased rates of leukemia and adverse pregnancy outcomes as a consequence of occupational exposure. Next slide, please. Now we come to another useful article which has been published in Lancet. This is in long COVID implications of for the workplace. The prolonged illness experienced by many patients following acute SARS-CoV-2 infection has been termed as long COVID by the self-organized patient groups formed on platforms like Facebook. Some of these patients have now been symptomatic for over a year. Long COVID impacts on ability to work, which has implications for employers, occupational health services, and the wider economy. The management of return to work and long COVID is similar to other prolonged health conditions, albeit with some COVID-specific consideration. From an occupational health perspective, it is important to appreciate that many patients have not yet been appropriately clinically evaluated. An occupational physician should evaluate workers and with awareness of the conditions listed like cardiovascular disease, perimyocarditis, microvascular angina and arrhythmia, neurocognitive like executive dysfunction and memory and speech, neurological like stroke, neuropathy, trigeminal neuralgia and migraine, and respiratory intestinal lung disease, pulmonary embolism, asthma, dysphonia, less common like endocrine, new onset diabetes or thyroiditis, dermatological, COVID toes and vasculitis rash, renal impairment also could be there, autonomic like postural orthostatic tachycardia syndrome, or sleep disturbance or gastrointestinal, or it could be immune, that is mast cell activation syndrome. The one must look, all occupational physicians should be aware of these long COVID implications. Next slide, please. Next slide, please. So this editorial is very important, and this shows importance of long COVID. As time goes by, long COVID will be detected more frequently and more commonly. Next slide, please. Another interesting article has come, which is in occupational medicine. It talks about working through COVID-19, Zoom, gloom, and Zoom fatigue. Zoom, gloom, and Zoom fatigue. COVID-19 pandemic has had a significant impact on the way in which we work across the world. Work is now undertaken at home, in bedrooms, kitchens, and living rooms using one of the many video platforms, including Zoom, WebEx, MS Teams, and Skype, to name but a few. Whereas many of us were aware of such technology before the pandemic, the rise in usage of these platforms in 2020 by a reported 360% in the case of Zoom has been encouraged by both government and employer messages to stay and work at home to control the spread of SARS-CoV-2 virus. But one must understand occupational health professionals need to be aware of these new and novel causes of occupational distress and ill health, and advise employers and employees that care needs to be taken with the introduction of new technology or increased use of established technology, especially when change occurs rapidly. There is still a need for considered introduction of technology supported by policies and guidance which support workers to be productive and prevent physical and psychological harm. And it is worth reading. This is in occupational medicine, the issue which is come out in July, 26 July, I've seen. So this would be worth visiting. Working through COVID-19, Zoom, gloom, and Zoom fatigue. Next slide. So now we go to two important events that are going to happen. Mainly they will happen online, and they will, first event is in September 3 to 6 that is the World Congress of Epidemiology. It was to happen in Australia. Now it will happen online. This event is held every 3 years, and the World Congress of Epidemiology will come to you virtually. The International Epidemiological Association and the Australasian Epidemiological Association will be conducting this event. The focus will be on methodological innovation in epidemiology, which reflects the innovative progress in epidemiology and public health. And this event is on 3rd to 6th of September, WCE 2021. Next slide, please. Another important event which will happen will be in September 22-23, a 4-day event, which was to actually happen in Canada. Now it will happen online, fully online and physically in Canada. That is the 22nd World Congress on Safety and Health. And the theme is Prevention in the Connected Age, Global Solutions to Achieve Safe and Healthy Work for All. Prevention, it's on everybody's mind. In the past year, safety and health at work has emerged as a critical issue. From September 2023 to 2021, the prevention community will come together to address the global priority at the 22nd World Congress on Safety and Health at Work. This completely online digital event offers world-class speakers, inspiring experiences, elevated networking, premium content, and access to global leaders. It's everything you have come to expect from the World Congress, only different. This is your invitation to convene and connect with your global colleagues at a critical time. It could be the most important meeting you will ever attend. And along with this World Congress, there'll be 2 important events, that is the videos for workplace prevention. So I'm just showing you 2 videos out of the many which have been submitted, which will be awarded during this Congress, World Congress on Prevention at the Workplace. So I would request Shivang to play these 2 short videos. These are entries for prevention of injuries and disease at workplace. Kindly share the videos, please.
Sir, just give me a minute, sir. I'm sharing.
Yes, yes. First video is of 1 minute, other video is of 3.5 minutes. And it shows how you can use communication tools, that's videography and storytelling, to improve the safety culture, occupational health culture in an organization, and how we can collaborate with our creative team to be more effective on the ground in our workplace. This is the first video.
A number of severe workplace internal traffic accidents happen every year. We will be looking at 3 occupational accidents that happened in Finland, where a non-track-based wheeled machinery has plowed into pedestrian. The first accident takes place in a composting facility where 2 employees work. One drives a wheel loader whilst the other works as a production manager. Both employees started to work as normal at 8 o'clock in the morning. The driver transports composting waste from the storage area to an incubator within the facility. The production manager has been going about their daily tasks and is going to take cardboard boxes to the recycling point. The shortest route to the recycling point passes in front of a sliding door used by machinery traffic. The production manager ended up under the wheels of the wheel loader, which was being driven out from the hall, and died of the injuries sustained. The second accident takes place in a port. It is 6 o'clock in the morning and the straddle carriers are in full operation. An experienced stevedore arrives for their morning shift. After the workers have been issued with their tasks for the day, the stevedore walks towards the container inspection area. They often take a shortcut past the barriers controlling machinery traffic. The stevedore is squashed under the wheels of a straddle carrier and dies of their injuries. The third accident occurs in a loading area. 3 employees have arrived for the evening shift. They have been tasked with unloading cargo from a lorry. One of the employees has brought over an electric forklift truck to assist with the task, and goes to pick up some pallets from the yard area. The second employee is walking over to the lorry. Third employee has already gone over to the lorry's trailer to wait for the others. The employee who has gone to collect the pallets loads 15 pallets onto the forklift and turns around towards the rear of the lorry. A warehouse worker is squashed under the forklift's wheels and dies immediately of their injuries. In order to avoid similar accidents, machinery and pedestrians must be able to move around safely in the workplace environment. We will go through the key factors promoting safety in internal traffic. The most important aspect is careful planning of traffic and adherence to rules in the workplace. Plan out separate, properly proportioned pathways and working areas for machinery and pedestrian. Ensure they are clearly separated from one another. Identify hazard zones and indicate them clearly. Gates and doorways will require special attention. Machinery must always stop before crossings, and speed must be proportionate to the conditions. Ensure there is a clear line of sight and sufficient lighting. Forklift trucks and machinery must also have functional lights and acoustic warning signals. Provide staff with instructions and create rules that everyone is to follow. Keep pathways in good condition and maintain order and cleanliness. Take particular care in wintry conditions. And what can we do to make sure pedestrians and drivers are aware of their surroundings? Drivers can improve their visibility by keeping the machinery's forks and buckets in the down position whilst driving. Additionally, lower loads enhance visibility and increase occupational safety. Pedestrians must ensure that they are also visible by wearing high visibility clothing. They may only pass close by to machinery when a driver gives a clear signal to do so. We cannot avoid dangerous situations completely, but we can work together to map out hazards, assess risks, and plan footpaths and machinery routes to ensure they are safe. When internal traffic within the workplace is well organized, we can avoid unnecessary accidents. A number of severe workplace
Let's go to the second video, which is very short. So you had a very wide range of scientific developments which have occurred in the field of environmental and occupational health during the past 1 month. And we shall also upload this video on the YouTube channel, which is a Enoch DigiConnect webinar platform on the YouTube. Please do subscribe to the channel and also watch, share, comment, and in your network you should spread so that more understanding of the latest development in the field of occupational and environmental health occur to the larger field of practitioners across in your network. Thank you so much for giving your time.
Thank you, Dr. Ajit Jain, sir. So you have given enough material to us, enough food for thought for the whole month. If we religiously go through all this material, it will take more than 1 month to go in depth of all this material. And to summarize, um, how widely you have covered all the occupational health and environmental topics. Number one was regarding the labor markets, that is PLFS report, indicating that there is a rise in unemployment and decrease in the workforce participation rate and decrease in the work participation rate. And unemployment increased more in the urban than in the rural areas, and the wages, they have also fallen sharply, and different statistics also you have given. So accordingly, we need to be aware of all these things, which is due to the pandemic, and it has also caused a lot of inequality amongst the society. And the importance of vaccination was also highlighted, like lag in vaccination in poorer countries will continue to generate headwinds for the growth. And until and unless the whole of the global population is vaccinated, we can't say that the vaccine, this virus is eradicated, and this will again emerge from these particular areas which are unexposed and not vaccinated. So we need to provide vaccines to all the populations across the globe. And regarding employment laws, also you have highlighted that employment loss has been bigger for the poorer workers in the poorer countries, and this climate hazards, they are threatening the vulnerable migrants in the mega cities, especially Mumbai, Delhi, Bangalore, Calcutta, Bhopal, and Punjab. They are the worst affected areas. So we all stay in all these cities. So we are also accordingly getting affected by these migrant populations. Then another issue was IITM's Pune's decision model support system to assess the contribution of the pollution sources in Delhi. So if this is successful, then it will be a good source for understanding what are the sources of pollution in Delhi, which we face every season, every year. And this ICMR Young Diabetes Registry, this is very important, sir. And we all must go through this to see the authentic data collection by the ICMR, which we can always refer and quote also for effective interventions at the workplace to control the non-communicable disease burden in our workforce. And the overview of the disease burden preventable through sound management and reduction of chemicals in the environment was also covered very widely by you, sir. And WHO data on total deaths attributed to chemicals in industries is also very alarming. And especially the children and the young adults who are affected by unintentional poisoning, that is also an important topic which we should be careful. And the important publication by ILO regarding exposure of hazardous chemicals at work and resulting health impacts, a global review, that is a worth reading. And we will definitely go through this ILO publication. Then occupational exposure to asbestos and silica, that was also important. And the chronic mercury vapor exposure and the 60 chemicals which are to which our workforce is exposed in electronic industry. This is also a new topic for us, at least. And further, you have clarified that this COVID-19 implications and the working through COVID-19, especially the people on virtual platforms, all these things, they need to be taken care by your occupational physicians. And we need to evaluate our workforce for all these long COVID complications, and the people who are working on these virtual platforms for a very long time, how their health is being affected and how it is affecting the industries. And especially the two events which you focus, they are very important, sir. The World Congress on Epidemiology and the World Congress on Safety and Health in September. So thank you very much, sir. A very wide coverage of all the occupational health and environmental health topics, and will give a lot of thing to go throughout the month. And we will again come with new topics next occupation OccuHealth Escapes. So now may I request the panelists and the participants, if they have any question or query, they can unmute their mic and they can.
Dr. Chandrasekhar wants to say.
Yeah,
Yes.
the chance to-
Thank you, Dr. Jain, for a very informative and very interesting presentation. It'll be really very useful for us, and thank you. Just wanted to thank you. Thank you very much.
Welcome. Thank you for attending.
Thank
Dr. Sanjay Rotitor, sir.
Yeah, because actually it was a very fast express tour of occupational health events, and it was a great data which was been shared in multiple important events. And I was also surprised to see the hypertension incidence, particularly in 35%, and also the obesity incidence. So we should be careful about that, and everything was good. Very hard efforts to collect the precious data. Thank you, sir.
Thank you.
Dr. Maruti.
Yes, sir. First of all, I want to compliment the Jain sir. It's express so much data was there. And, obviously, I mentioned Sandeep sir, it's like, all it takes to gather that much data. The points are, nowadays we are seeing more of the vitamin deficiencies and even vitamin B12 and even is there
Your voice is breaking, Dr. Maruti. Your voice is breaking.
Sir, 1 second. One second. Sir, am I audible now, sir?
Yeah,
am I
yeah.
audible, sir? No?
Yeah.
Yes, better.
Yeah. Nowadays, we are seeing more cases of the infertility and vitamin D3 deficiency and thyroid issues and vitamin B12 also. Is it because of some of the industrialization has led to heavy element contamination? Even more, it was there in the urban area, but nowadays has shifted to the rural areas also. Just in highlight about this, sir. Anything? Just in single stretch, I just asked the question.
Very true. That's a fact, actually. Infertility in urban areas, and now in rural areas also, that is a hidden problem. Pesticides could be a cause, or chemicals could be a cause. Unless we suspect, we will not investigate. If we investigate and gather evidence for toxicity, we should be able to measure the exposure as well as the actual levels in these affected individuals. The people who are managing infertility, they also corroborate the fact that you mentioned, especially in a country like India, where a lot of chemicals are manufactured and people come in contact with them without actually taking regular precautions. Even in the workplace, there is exposure, and the explosion of, you must have seen explosion of IVF clinics. That could be a precursor. That could be an evidence, in fact, a marker, which could be utilized for estimating. And you had seen the chemicals exposure impact, the health impacts. Infertility was there in number of them. So there is a possibility. But unfortunately, the data in our country is very, very limited.
Fine. Thank you, sir. Anything on B12 deficiency, sir?
B12 deficiency is not being documented as such as a workplace risk, and burden of disease also is not there in the GBD study of 2019 specifically. So it's very difficult to actually talk about it from this perspective. GBD study is the most important study, which shows you the occupational component or the contribution of occupational exposure. So there's no way to tell at the moment.
Yeah, I just have thought, I just want to share my thoughts, sir. Is there anything which is having impact on RO water and all those kind of things, which is affecting
No,
our
that also,
routine commensal?
no, that there is no evidence at the moment.
Fine, fine. Thank you, sir. Thank you so much, sir. Thank you.
So thank you, Dr. Maruti. Dr. Tyagara, sir, if you have any question or comments, you can unmute. Else we will, yeah. Sir, you have to unmute yourself, sir.
Okay. Okay. Thank you, sir.
Yes.
Thank you very much. Sir, regarding Dr. Marthi's question regarding vitamin D3 and vitamin B12, I think the tests are very, very costly. And most of the doctors write vitamin D3, vitamin B12. If you go to the major big corporate hospital, they write, and the cost is very much about 4,000 rupees for both vitamin B12 and vitamin D3. And we can start vitamin D3 and vitamin B12 in every calcium whenever we give vitamin D3 1,000 units per day or 60,000 per week. Or if there is a deficiency, if you find that if there is any bone pain, weakness or any fracture, osteoporosis, osteopenia like that, you can start giving 6 lakhs Architol or Uprise D3 injection we can give. That is one. Then vitamin B12, methylcobalamin 500 mg. In many of the cases, they have come out with this one. That also we can be given. But only thing is, some of them as writing the investigation, which is very, very costly. At present, the common man, people cannot afford that kind of one. The second thing, sir, congratulations to our Dr. Rajiv Kumar Jain. Wonderful speech. And one is updating everything, and really we wanted this to be continued for a long time, especially in the COVID times. And congratulations to Dr. Sandeep Sharma ji. You are also taking, I think you are also busy being a very good in a position, and you are spending your time with us. And my request to all the other seniors is, see, this is the Delhi is the AOSD is the only conducting all over India. I think this is the best brand which is conducting this kind of webinars. People should utilize it because the knowledge is the power today. Yeah, you see America, you see Germany, you see UK. There the things are very beautiful and very everything. The COVID has come down. Even though people are very much interested to go outside and enjoy, and most of the people, they spend their time in outside. But in India, it is not like that. But in spite of that, the COVID rate has come down in Brazil, come down in USA, come down in European countries. And see, they have, in the Olympics, if you see, and yes, except India, almost all countries are prepared in a wonderful manner, especially COVID times. They have used those time itself, utilized the epidemiologist and occupational specialist, and they have put them in some bubble place, and they have started training and all. They are achieving so much. So small countries are all achieving, whereas a very large, huge population country like our India is struggling to get a gold medal. Thank you very much, sir. Rajiv Kumar Jain, sir. I think you are doing wonderful job, and really you are enlightening us with so much knowledge you are giving to us, and we are very much grateful to you. At the same time, we will thank you to Dr. Sandeep Sharma ji, because before this COVID, we are actually, to tell you honestly, we were not knowing so many things. And after once you started, we also go through that, and really we are achieving a knowledge. And all these things, credit should go to AOHDT. Thank you very much, sir. Thank you.
Welcome.
Thank you, Dr. Tyagara, sir. And thank you to all the participants and the panelists. Definitely, knowledge is the power, and that was the only reason why we started this this particular program on this DigiConnect webinar platform. And as you rightly said, more and more people, they should join, and we also try not to keep everything to ourselves. whosoever attends physical on virtual platform, that's okay, but rest of them, they can refer it on our DigiConnect webinar YouTube channel. So all things are available, knowledge is available. So we don't want to keep the knowledge to ourselves. We want to spread this knowledge to everyone. And whosoever, because we have seen that people might not get enough time to attend the programs regularly, but they can always refer it on our YouTube channel, and definitely we will continue with these programs, because learning is lifelong and it is a journey. It can't be over with pandemic. So we will continue, because new things will emerge and new scenarios will come, and new things from the situation need to be learned by every one of us. And definitely we'll continue it, sir. We'll keep this in mind, and we will do the needful. So with this, we conclude this today's session. It was a lovely session with lot of insight on occupational health and environmental health issues across the globe, local, regional also. And as rightly said, sir, we will continue tomorrow also. Tomorrow there is a the COVID EPID updates, along with a guest speaker who will enlighten us on this heart attack, and how to take care of heart attack, especially during this COVID times. And we have to remove the fear from our people, because lot of cardiac complications, they will feel that because of blood thinners, because of hypertension, or because of the COVID complications, they may appear in the post-COVID patients, and especially during COVID infection also. So all these points will be clarified. So we have got a renowned faculty tomorrow. He is also Dr. Rajiv Agarwal. He's a DM cardiology and director of cardiology center at Max Saket City Hospital. So he's a renowned faculty, and both our faculties are renowned faculties tomorrow. So please do join the program tomorrow also, and refer to our DigiConnect platform YouTube channel whenever you feel like learning something, or refer to our repository of 79 videos, as Dr. Rajiv has said, and do subscribe to the channel. Thank you very much. Thank you all the participants and all the panelists.